I'm Andrew Racine. I'm the Chief Medical Officer at the Montefiore Medical Center, which was a pioneer ACO, is a pioneer ACO, and it's in the Bronx, in New York. We take care of a population of folks who are not only generally underserved, but also low-resource folks. I think what you're looking at here today is what responsive government looks like. And by that I mean, and I'm going to echo many of the comments that Bill and Ken others have made here, what happened here was the folks who designed this legislation, Senator Wyden, Senator Isaacs, and the others, took a look at what the pioneer ACO experience was like. And they found what worked on the basis of input that they got from those of us who were doing it. And to get back to the question of how does this differ from ACOs, it's an important question. And there are elements that came out of the ACO experiment that were incorporated into this legislation that improves on it. What are those elements specifically? Number one, in the ACO experiment, the way it currently works, there's nothing to say that you can't conduct an ACO with a fee-for-service payment arrangement, and many of them do. The fact of the matter is that those of us who are in places like the Bronx, we take care of about 500,000 people. 270,000 of those 500,000 are in some shared risk arrangement. It is really impossible to deliver the kind of care you want to deliver unless you move away from fee-for-service, unless you put the nexus of decision-making for a clinical decision in the same hands of the people who are at risk for the finances. That's what you want to do. That's what the bill does. That's extremely important. Number two, we also know, on the basis of what we've done in the ACO in the Bronx and other places, that if you really want to make inroads into saving costs, you have to concentrate on folks who are going to cost money, and those are folks with chronic illness. So this specifically incentivizes people to go to look for the patients in their population who have multiple chronic conditions and to see what can be done for them. That's the second thing. The ACO doesn't do that. This does that. The third thing, which is really important, is that it incentivizes team-based approach to care. You've already heard this from some of my colleagues. You cannot take care of people with chronic illness in a single sort of the Marcus Welby, if you will, approach, where you have a really caring physician who's got a one-on-one relationship with their patients. There simply aren't the resources, and the reason for that is that chronic illness begins with the social determinants of health. And if you're going to address those social determinants of health, that's not something that happens in the exam room. You need a team of people that are going to do that. This legislation also speaks to that issue. And so I think all of those things together, plus other elements of it, incentivizing the patients themselves. There are elements in this bill that incentivize patients to also save costs, and the ACO doesn't quite do that. So this builds on the experience of those of us who did the ACO and who are doing the ACO and actually gaining real savings. I mean, Montefiore saved $23 million for the federal government working in its ACO in the first year. It builds on what we found out doing that experiment and just moves the experiment forward. That's what legislation is. It's an iterative process. And I think this is a real improvement. And then the only other thing I would say is that since I'm a general pediatrician, I don't normally deal with folks in the Medicare program. I would be remiss if I didn't point out to the audience that this is a precept that originated in pediatrics in 1967. Patient-centered medical homes come from pediatrics. And I know that Senator Isaacson is a big supporter of children's hospitals, but this came out of pediatrics. It was a design for patient-centered medical home for children with chronic illness. And I'm just very happy to see that the folks in the country are finally catching up with what the pediatric community has known for 40 years.
Let's all agree pediatricians rock too. Folks had a few more questions.